There's a version of you that walks into your next doctor's appointment, sits down, and simply says yes. Yes to the new prescription, and yes to the specialist referral. Yes to coming back in 3 months for another test. And there's another version of you, one that walks in with 3 specific questions written in a notebook. Questions that signal to your doctor immediately that you are an active participant in your own care, not a passive recipient of it. Today, I'm giving you those 3 questions. They come from the medical literature itself, from the fields of shared decision-making, evidence-based medicine, and a growing clinical movement called deprescribing that is reshaping how geriatricians and pharmacologists think about medication in people over 65. These questions won't make your doctor uncomfortable. They will make your conversation better, more precise, more honest, and far more useful to you. Stay for question 3. It's the one that tends to change the entire tone of the appointment. Before the questions, you need to understand the environment you're walking into. Your doctor sees on average between 20 and 30 patients a day. A typical office visit for an established patient lasts about 15 minutes. In those 15 minutes, your doctor is reviewing your file, updating records, ordering labs, and making prescribing decisions. This is not a criticism, it is a structural reality of modern primary care, and it creates a well-documented phenomenon that pharmacologists call the prescribing cascade. Here's how it works. A patient is prescribed a medication. That medication causes a side effect. The side effect is interpreted as a new symptom. A second medication is prescribed to treat that symptom, and so the list grows, not because each drug is wrong in isolation, but because the system isn't always designed to step back and ask, does this person still need everything on this list? Estimates suggest that 45% of older adults are exposed to polypharmacy, the use of 5 or more medications simultaneously, and 58% to potentially inappropriate medications. Evidence indicates that polypharmacy in the aging population contributes to treatment non-adherence, higher incidence of adverse events, and increased healthcare expenditures. None of this means your medications are wrong. Many of them may be exactly right for you. What it means is that the questions you're about to learn are not just valid. They are clinically supported. They are the same questions that geriatricians, clinical pharmacists, and evidence-based medicine researchers are asking on your behalf. You are simply going to start asking them yourself. Question number 1. And this requires a small but important lesson in how medical evidence actually works. The question is, what is the absolute risk reduction for someone my age with this specific treatment? Write that down, absolute risk reduction. Here's why this question matters so much. When a new drug is approved and marketed, its effectiveness is almost always communicated using a number called the relative risk reduction. It sounds impressive. A drug reduces your risk of an event by 40%, by 50%, sometimes more. But that number, without context, can be deeply misleading. In a high-risk group, a 50% relative risk reduction would decrease absolute risk from 20% to 10%, a 10-point difference that is genuinely impressive. However, in a low-risk group with a baseline risk of just 2%, that same 50% relative risk reduction would decrease risk from 2% to 1%, a 1-point absolute difference. Same percentage, completely different real-world impact. Presentation of absolute risk has been shown to be more effective in communicating with patients, and yet absolute measures of risk are not always assessed or included in clinical guidelines, and therefore not commonly used by health practitioners when talking to patients. So you have to ask. When you ask your doctor for the absolute risk reduction for a person your age, with your specific health profile, you are asking, out of 100 people like me who take this drug, how many actually benefit? That number, sometimes called the number needed to treat, tells you far more than a headline percentage ever could. Your doctor may need to look it up. That's fine. That's the point. It signals that you want the full picture, not the summary. And if the absolute benefit for someone your age turns out to be modest, if the medication helps 2 people out of 100, that doesn't automatically mean you shouldn't take it. But it does mean the conversation about side effects, cost, and pill burden becomes very different. Much more honest, much more yours to participate in. Question number 2. This is the one that addresses something almost no one ever asks, and almost every patient should ask this. What is the exit strategy for this medication? Most prescriptions are written with a start date. Very few are written with an end date or a reevaluation plan. They become, in effect, permanent by default, not by deliberate clinical decision, but by inertia. There is a growing and legitimate clinical field dedicated to addressing exactly this. This process is called deprescribing. Deprescribing is the planned and supervised process of reducing or discontinuing pharmaceutical treatment that may no longer be effective or cause harm, with the aim of reducing the burden or harm of medicines by improving quality of life. This is not a fringe concept. It is increasingly endorsed by geriatric medicine societies, clinical pharmacologists, and patient safety organizations worldwide. Reducing polypharmacy by purposeful deprescribing has been shown to reduce medication-associated emergencies and hospitalizations. When you ask about an exit strategy, you're asking for specific things. Is this medication for 3 months or indefinitely? When will we reevaluate whether I still need it? What would need to change in my health for us to consider stopping it? And what are the signs that it's causing more harm than benefit? These are not questions that challenge your doctor's competence. They are questions that invite your doctor to think about your care as an evolving plan, not a static prescription list. Deprescribing has been demonstrated to significantly reduce mortality when approached in a person-specific manner and often carries no adverse effects on quality of life or health outcomes. Some medications are genuinely lifelong. Others were prescribed for a specific period and simply never revisited. Asking this question helps both you and your doctor know the difference. We have one more question to go, and this is the one I want you to pay close attention to. Because it doesn't ask for data, it asks for something more human than that. It asks your doctor to step out from behind the guidelines for just a moment and speak to you as a person, not a protocol. Don't go anywhere. Now for question number 3. If this were your own parent, your mother or your father, at my age, with my health history, would you recommend this specific drug as the first step, or would you suggest trying a non-pharmaceutical approach first? This question does something the other two don't. It moves the conversation from clinical guidelines, which are written for populations, to the specific human sitting in the room. Guidelines are built on averages. They are designed for groups of thousands of patients. You are not an average. You are one person with one history, one set of priorities, and one definition of what quality of life means to you. When a doctor has to answer the question, what would I want for my own parent? They naturally shift their thinking. When prescribing a new medication, the long-term goals of the patient must be understood, and a thorough discussion of the medication's benefits and risks should occur, including alternative therapies such as preventative or non-pharmacological options. For many conditions that are common after 65, mild hypertension, early-stage metabolic changes, sleep disturbances, low mood, joint discomfort, there are non-pharmacological interventions with meaningful clinical evidence behind them. Structured exercise, dietary changes, sleep hygiene protocols, physical therapy, stress reduction. These are not wishful thinking. They are first-line recommendations in several major clinical guidelines that sometimes don't make it into a 15-minute appointment. This question gives your doctor permission to mention them. It signals that you are open to a conversation, not just a prescription, and it invites a level of clinical honesty that the standard format of a medical visit doesn't always allow. Your doctor may still conclude that medication is the right first step for you. That's a completely valid outcome. But now you've had the real conversation, the one where the decision was made together, with full information rather than handed down from a clipboard. That is shared decision-making, and it is associated with better outcomes, higher treatment satisfaction, and better adherence. Because when you understand why you're taking something and you've agreed to it on your own terms, you're far more likely to take it correctly. Let me bring this together. 3 questions. Write them in a notebook. Put that notebook in whatever bag you carry to your appointments. 1. What is the absolute risk reduction for someone my age with this treatment? The question that gets you the real numbers, not just the headline percentage. 2. What is the exit strategy for this medication? The question that turns a prescription from a permanent fixture into a clinical decision with a plan. 3. If this were your own parent, would you try a non-pharmaceutical approach first? The question that invites your doctor to think about your care as a human being, not a checklist. None of these questions are confrontational. None of them require medical training to ask. All of them are supported by published clinical literature, and all of them signal to your doctor that you are the kind of patient who reads, thinks, and participates in their own health. That is not a burden on your physician. Good doctors actively want patients like that. It makes the 15 minutes more productive for everyone. One last thing, and this matters. These questions are tools for conversation, not weapons for conflict. Your doctor has knowledge, context, and clinical judgment that no YouTube video can replicate. Use these questions to open a dialogue, not to win an argument. The goal is always the same: better decisions made together that serve your independence and your quality of life. Which of these 3 questions feels most relevant to your situation right now? Tell me in the comments. I read every single one. And if someone in your life could use this conversation, share this video with them. Sometimes the most important health decision someone makes is because a person they trusted thought of them. Stay curious, stay informed, and I'll see you in the next video.